Hi, I'm Jon Keating from Active, Head of Business Operations. We're here today with Kris Sorenson from University of Keele. What we're going to discuss today is the active academic partnership that Active have with University of Keele. Kris, would you like to say a little bit more about that?
Sure.
And what it is?
So I'm Kris Sorenson. I'm a Senior Research Fellow at the University of Keele. And my area of research is around implementation sciences. So how do you help move evidence around what we already know works into practice, whatever practice is. And yes, we've started the Active Academic Partnership, which is looking at how we can use some of the evidence base and put that into practice to help physical activity become more an integral part of health and care delivery.
So the main focus of the AAP and what we want to achieve in simplistic terms, what is that?
Right, so the AAP, simply put, actually it is layered, but I think the best sort of sentiment that captures it is a quote by an inventor called Buckminster Fuller. Love his name. And he basically says, if you want to change how a person thinks, give up. Instead, give them the tools that they can use, and using those tools over time causes them to change how they think. So I think what academic partnership aims to do is to offer different tools and processes from research in different fields of science to all of the people, all of the stakeholders like Active and health and care providers, give them those new tools that help them to have different kinds of more effective conversations and yield more effective kind of partnership delivery, like on the ground.
Okay. So what have we learned so far from the Active Academic Partnership?
Yeah, the AAP has learned so much. It's really hard to nutshell it. So I'm going to talk about it kind of conceptually, and then questions, comments beneath can help us drill down the brass tacks. What does that actually mean? But I would say the biggest thing that the AAP has learned is that we need to be intentional about how much we go along with the way the system already works, funding systems, referral systems, all of those kinds of things. We need to be intentional about how much we go along with the way that they work, and how much and when and where we push back a little bit and help that system to move along to something that is more effective. So going along with it can help us kind of win short-term sort of gains and get a toehold and some business outcomes that keep us going. Pushing back says, actually, we're not going to deliver siloed activities or interventions anymore. We need to be doing this collaboratively. So actually, I'm going to negotiate with my commissioners and say, don't commission physical activity on its own right now. Commission physical activity plus social prescribing plus something else. And that package of delivery works together. That also helps the system to learn how not to be focused on a singular health outcome when that health outcome is achieved by a group of people. So it's a bit like saying to you guys, give us physical activity for cardiac patients, but we're going to measure your service, and therefore your future commissioning, on how many people you bring off blood pressure medication. Well, physical activity may well be doing a very good job on its own, but if everybody goes to the pub or the chippy on the way home, then although you've done your job, we still won't be reaching those health gains, but you're being held accountable for it, if you see what I mean. So it's not that siloed delivery and outcome.
Yeah. So what are the next steps, and what actions do we need to take as a sector? We keep calling ourselves leisure. We shouldn't probably refer to ourselves as leisure anymore. Health and wellbeing space. But ultimately, in terms of what we've got, in terms of that public sector leisure as we're known at the minute, what are the next steps and what actions do we need to take?
Right. So the next steps and actions really are around more of that intention of going along with a system that it currently exists, and choosing when and how to push a little bit on it and to help the system to learn. So in order to do that, we really have to deepen the understanding of ourselves as a sector. What are our strengths? What do we have to offer? Deepen our understanding of the stakeholders that we want to work with. And ultimately, the actions behind that are about having more of those conversations. So we've had lots of conversations, and you put a blog out about kind of, those siloed echo chambers, right? So the single biggest action, I think, to take is to have many more of those conversations with the stakeholders that you ultimately want to be working with, and to be having better conversations. So using some of the tools that we've used over the course of the AAP, the participatory research methods and generative conversations and liberating structures and all of those kinds of things, using some of those tools when you have the conversations, so your conversations are different and more effective increasingly. But the biggest single action is don't stand there saying, why aren't we talking? Invite people in and invite them again. And if they say no, invite them again.
Okay. So what are our biggest opportunities to connect health and leisure as things stand?
So again, I think it's not completely opinion. There's some evidence behind it from what we've gathered with the AAP, but you're asking me to kind of interpret it.
Yeah.
So sticking my neck on the line slightly, I think the biggest single opportunity between healthcare and physical activity provision, is for physical activity providers to lead the health and care sector about how to do the things that they want to achieve. So there's a lot of evidence about what to do. We all know we should be more active. We all know activity should be being referred to by healthcare providers. We all know we should take up those referrals, etc. Like, we know what to do, but the what isn't happening to its fullest effect. So there's a lot of untapped potential around what we could be gaining from physical activity. What I've observed is that the physical activity provision sector has a lot of knowing about how to offer physical activity in ways that are meaningful to people, around what matters to them. And health and care really want things like that. They want pushing care into the community, and they want integrated care. But I don't think they yet have many partnerships where people really know how to make that happen. So the opportunity really is for you guys to lead the other stakeholders in the system and show them how.
I think what we do particularly well, and probably for 30 years or so, we look after 10 to 15% of the population that are engaged in coming to the offer, the current offer that we have. I guess the challenge for us, trying to be more in that preventative health space, is how do we engage that 85-90% that maybe are not engaged with us so far? Yeah.
So I mean, I think that is apart from as part of leading other parts of the system, is that piece where you get to choose your own destiny. You design it. Don't wait for health and care to show you what they want to commission. Ask for what you want to give a little bit. So a bit of that designing your own destiny. And it is about, what's your business model? Do you want to, how much primary prevention do you want to do with the 85% that you're maybe not tapping into yet? How much secondary prevention do you want to do with many more of the people with long-term conditions who are not walking through your door yet? And how do you want to go about doing that? Because as part of the AAP, we've done that consensus roundtable with all of the stakeholders. They've described that together, all of the different players in the system agreed the single thing that they want to do jointly is to self-activate many more people in GM towards physical activity and towards managing their own care, owning their conditions rather than suffering from them.
Yep.
So it's the opportunity here is, how do you want to play a role in that? Do you want to provide services for people already activated? Do you want to be part of activating people? Do you want to do a bit of both? How? And how will you play with other people? And that goes back to those conversations. That's why so many more of those conversations need to happen for this to be a truly integrated care provision.
Sure. I think the answer to that is we want to activate and we want to provide. So what our challenge is how we get there. So we've talked about the opportunities, Kris. What are the barriers or blockers currently in making that happen? Well, it sounds quite utopia at the minute, doesn't it? And we know that it's the right thing to do, but what are the blockers and barriers to get there?
Well, I mean, that is the single question that the AAP is built around, I think, is to understand what are the barriers. Because the barriers to achieving that utopia, what we all know to be right, is we all know it's right, so why the heck aren't we doing it? And it is discovering why aren't we doing it? What's stopping us? The biggest single barrier that we've encountered across the AAP and all of our allied portfolio of work, which feeds in and out, is sort of the number of ways that we get in our own way. It's like an age-old barrier for pretty much anything we do in life. How are we getting in our own way? One of the biggest ways that we get in the way of ourselves is when we let ourselves go into an existential crisis. So that happens two ways. Either because we feel like we're under threat, maybe our commissioning is a little bit under threat, and so there's a little bit of panic to stabilize. How can we make sure that, and so then you go out looking for, well, what would you like from us? How can we serve you? And it's a little bit servitude rather than leading.
Okay.
So that's one of the existential crises. The other one is when you become fearful as you come into collaboration with people, that part of the system or that person is going to duplicate what you do and you become less valuable. And this problem is big enough for everybody to play a role. Like, there is no danger that people are not going to be useful in this.
Where those barriers have been broken down, and an opportunity has been turned into reality. Do you have a strong example of that?
Yeah, so I want to be clear, like, strong examples of when we've taken down those barriers, they're everywhere. Like, there's a lot of people across GM Active and beyond who are doing them. So I if I shine a spotlight, it isn't because I'm forgetting about everybody. The one that springs to mind immediately is Bolton Community Stroke Team, who wanted to offer more physical activity as part of their rehab services. And they got some quality improvement funding to support a bit of a pilot project to see if they could make that happen. They went into it with some preconceived ideas about how to actually offer physical activity. So a bit of a build it, we will come model. They thought personal training might be the answer. And when we first started supporting that project, we kind of did just a little bit of a quick sense check going, how many stroke survivors have actually asked for personal training? How many times is that an unmet need for service users? And also a sense check with what's the unmet need for the clinical team in terms of providing their services. And after a bit of a refinement, it moved from being personal training into health improvement practitioner, and then coming into an actual part of the clinical multidisciplinary team. As they did that, they sparked some existential crisis from within their own team and from wider stakeholders. People being worried that this health improvement practitioner role would overlap on their services, and then they wouldn't get the referrals through, or it overlaps on their role clinically and maybe wouldn't be being done to the same quality, or makes them somehow not necessary. And it's only been through the experience of actually listening to one another's fears, overcoming those and working together, that actually now they're starting to see that in fact that health improvement practitioner role has increased referrals out to wider stakeholders, including physical activity partners. And that for the clinical team, in fact, it's helped them feel a little less of the burden of the caseload. I don't mean that in a bad way. As clinicians, everybody is very caring. So you really feel for the patients and the service users that you're working with. But it's helped them to feel more connected, that they've got more services that can help them help those people more holistically.
Okay, thank you, Kris. The ultimate success of AAP, or the Active Academic Partnership, what does that look like? How can we, GM Active, University of Keele and other partners sit there and say, yes, that was a success?
Right, so for me, what success looks like for the AAP is like a few different levels. On one level, I just hope that GM Active, your wider stakeholders, all of the health and care stakeholders, have maybe a better understanding, an experience of working alongside of academics and what that can offer and what it can't. Does it slow us down? Because that's a bit of a thing that's out there, that academics might slow things down when actually we need to put things into practice on the ground. Does that happen? Does it not? And what tools do we offer? What value do we add? The second thing I would think would be success is obviously many more physical activity referrals happening from not just healthcare providers, but all of our partnerships across the integrated care system. And the last thing I would say is actually I would love it if GM actually lived out that consensus statement they arrived at the roundtable, where their ambition is to activate many more residents in GM, be self-activated towards physical activity, towards their own care, towards their own self-management. I think if we could stand up in front of the government, in front of the World Health Organization, in front of all of the academic knowledge base and say, look what GM did. Their residents are much more self-activated. They're much more likely, they feel more confident, know where to find services for themselves, know how to get to those services rather than waiting for a healthcare professional to show them or to support them. If we could say that, I can't imagine that wouldn't be an outrageous success.
Isn't our role to try and help prevent long-term health conditions rather than manage long-term health conditions, or is it both as a sector?
Oh, so the role in terms of primary and secondary prevention, or primary prevention and then management, it has to be both. We're never going to not need physical activity to be part of the scene in helping people live better with the conditions that they have. That's never not going to be a thing. Do we need to use physical activity much more to sort of unleash the preventative potential? 100%, but I don't think you could choose. I think you have to do both, in my opinion.
Okay. Are there any quick wins?
Oh, well, define quick win. It has to be conversations, more of the roundtables. Like, that was, if I say so myself, when I was in that roundtable room, that felt like a bit of a magic moment across different stakeholders. It felt like they saw each other to a little bit better effect, and they agreed something that was slightly more explicit than maybe we kind of know generally what's right, and we know we should be working together, but it got to a little bit more of the brass tacks.
Okay.
More of those conversations for me has to be it.
So if we think GM Active, the coalition of 3,500 staff across our 12 partners, is there a quick win with them that we need to approach?
Yeah, definitely. So the quick win in terms of, like, the GM Active coalition and workforce, for me, single-handedly, is that you guys, like I said earlier, apart from many other, or more than many of the other stakeholders in the system, have the time and the skills already to be talking to people about what matters to them in their own communities, unleashing that potential, maybe developing those skills a little bit more, like some more motivational interviewing training, and talking about those more explicitly, I think has to be a quick win.
What's our next steps?
So our next steps, so we've continued the AAP into a 3-year PhD studentship, which will be looking at service non-users. So the 85% that may not be walking through the doors already, why not? What kind of a conversation do they need to be having about physical activity? What really matters to them?
I guess we do have to be careful with the 85% statement, because it's actually, there could be an awful lot of that percentage that are actually doing things in terms of going out walking, cycling, or doing their own things, but not connected to our offer, but they're still out there doing. So we probably need to be a little bit careful with that stat, don't we?
Yeah, 100%. Yeah. But we're talking about the people who are not yet taking up the physical activity offers wherever they live in the community. And why not? And what kind of a conversation do they need to be having about it? And what does physical activity need to look like for them? So that's what the PhD studentship is.